in the hyperacute phase, right? Detection, dispatch, delivery, door, data, decision, drug, device, and disposition. Right, detection is big. We have to recognize stroke symptoms. That's one of the biggest barriers that people don't recognize. You know, my dad, it's a horrible, like I do this for a living, and he's still telling me that he drug his leg to bed, and when he says it, he's like, tells me the story like that's a thing he does. I had to drag my leg to bed, and then I went to bed. And then what made him call my brother first, who's not a nurse, is or not in healthcare at all, is his blood pressure in the morning was like 220. And so that's the only thing that saved him from having really severe deficits. He has right leg weakness and some sensory deficits, but he got very lucky because his blood pressure was enormous all night, you know, and has probably, assumingly, has some good collateral flow. But he called my brother and he's like, my blood pressure is this, but also not like, I can't use my leg, like nothing like that. And so, but that's that piece, that early detection is what matters. Activation of 911 is our expectation, right? We still have about just over 50% of the population with an acute stroke arrives to the emergency room by 911. There's just over 40% still arrive by private vehicle with an acute stroke. So we have a lot of work to do on that. Delivery, that involves getting people to the right facility for the right treatment that matches their needs and recognition of that process. Door is the arrival into the emergency department and stroke team in place. And then decision, data, of course, involves being able to get the right imaging and make that determination about what's going on, making the decision for treatment, the door to drug time, door to needle, as that, you know, what is our intervention, what is our time frame, and then, of course, disposition as to what is the next steps. So as we talk about ischemic strokes, ischemia means impaired blood flow and impaired arterial blood flow. And there's 3 different causes that can contribute to the development of an ischemic stroke: embolic, thrombotic, or occlusive. Embolic, of course, is a blood clot or debris that travels to those blood vessels. Thrombotic is a clot that develops in those blood vessels. And occlusive is related to cerebral vascular occlusive disease, so plaques that obstruct blood flow in those arteries. In that hyperacute phase of ischemic stroke management and ischemic stroke care, as we're getting that determination, the most important part is determining the core infarct and then the zone of the ischemic penumbra, that tissue that is at risk for becoming permanently damaged. So the core infarct is the tissue that is irreversibly damaged. That ischemic penumbra is the tissue that is at risk for being irreversibly damaged. But if blood flow is restored, can be just fine. So things that affect brain tissue injury rates, of course, the speed of that stroke onset or the speed of the insult, the amount of time that the tissue's ischemic, collateral circulation, the systemic circulation and perfusion, some hematologic factors like bleeding disorders, clotting disorders, blood sugar, and metabolic factors like that as well. So 2 neuronal death pathways, if you remember from nursing school or textbooks. This can be overwhelming. I just like to try to simplify it. So cell death occurs by 2 pathways, necrotic or apoptotic. Necrotic cell death is the tissue that's directly injured. They die because of the infarct, the lack of blood flow, the lack of oxygen, the lack of glucose. And then apoptotic cell death is programmed cell death. So that is how the cells in the ischemic penumbra die if their blood flow is not restored. Does that make sense? Okay. Ischemic risk factors that are important to know, modifiable, of course, that we have to address, document our education to, address in primary and secondary prevention strategies. Hypertension, hyperlipidemia, glycemic control, lack of exercise, poor diet, tobacco use, alcohol use, and obesity and body mass index. And then non-modifiable risk factors, age, gender, family history, ethnicity, which, there's a lot of structural pieces as well and systemic pieces that go into access for a lot of different people that are non-modifiable in risk factors that I just like to pay attention to. When we think about medical diagnosis and risk factors, medical diagnoses that contribute to the development of stroke: diabetes, arrhythmias or atrial fibrillation, MI or heart failure. A TIA will, if somebody's had a TIA, that puts them at immediate risk for stroke development, unless it's fixed, the cause is fixed. Hyperlipidemia, having an atrial septal defect or a PFO, a patent foraminal-valley, those can contribute, or medical diagnoses that contribute to risk factors or risk factor for stroke development. And then prothrombotic states, clotting disorders, hematologic disorders, things like that. Cancer, trauma, COVID, lots of prothrombotic pregnancy, lots of prothrombotic states that can contribute to that. So transient ischemic attacks. TIAs are a stroke warning sign. One of the conversations that I've had with an ED physician, we were working on, especially during COVID, we were working on determination for patients who come in with stroke-like symptoms, right? And if they can go to OBS or they go to stroke unit or they go to ICU. And so his question, the way he worded it was, well, how many people who have had a TIA can become positive for stroke in their OBS piece, right? He wanted to know, what he was thinking was, how many of the people are we going to put in the OBS unit who are going to be to end up being stroke positive? Which we don't know that until imaging. You've either had a TIA or a stroke. What we know is you've had stroke-like symptoms. With a TIA, they resolve, but we still have to get imaging. If you have an area of ischemia on imaging or on MRI that shows that you've had a stroke, you've had a stroke. You didn't have a TIA that became a stroke. You had a stroke, right? And so that's the way to be able to think about it. Even if the symptoms resolve, we do imaging and it's present on imaging, the ischemic area of infarct is present on imaging, you had a stroke, you didn't have a TIA. And so that's an important thing. That was a weird way that he asked that, but that's one thing that I like people to think about. We either have a TIA or we have a stroke. We don't know at the beginning sometimes because the symptoms can resolve. And so a lot of the times we should go through the same process. And so TIAs are an episode of focal cerebral ischemia and neurologic dysfunction, not resulting in permanent infarct. That's the difference. If you have a permanent infarct, you've had a stroke. And so diagnosis that makes integrating that clinical picture, right? We have to look at what was the focal symptom? Was it extremity, face, legs, arms, speech? What was it? How long did it last and how long before it resolved? What were the neuroimaging results? Because again, remember, if they've had the symptoms, they resolved, but they have the area of infarct on MRI or on CT, but on MRI, you've had a stroke. That's the diagnosis. And then the diagnostics and workup afterwards. So the ABCD2 score is a good score to take a look at and just kind of familiarize yourself with. It helps grade the severity of stroke risk after having a TIA. So the higher the score, the higher the risk of stroke after TIA. So the factors that go into that ABCD2 score: age, blood pressure, clinical features, if they had unilateral weakness or speech disturbance without weakness, the duration of symptoms, if it lasted up to 1 hour, 59 minutes, that's 1 point. If it lasted longer than 60 minutes, that's 2 points. And if they live with and have a comorbid condition of diabetes. So in general, just some things to pay attention to or to know about the ABCD2 score. 0 to 3, a score of 0 to 3, about 1% of the population has a 2-day stroke risk. And most of these patients are outpatient follow-up. And they have about a 3%, 3.5% 90-day stroke risk. An ABCD2 score of 4 to 5, they have a 4.1% 2-day stroke risk and up to about a 12% 90-day stroke risk. In the old world of not having bed crunches and staffing crunches and healthcare in the same way, a lot of these patients would get admitted and be followed up with and their determination of their treatment plan for what is generally commonly carotid issues, large vessel issues, plaques. You need an endarterectomy. Why is this happening? What is the procedure? Let's get it done inpatient. That's not always true now. 4 and 5s may go home and get rescheduled in a couple of weeks for follow-up. And then a 6 to 7, it has an 8.1% 2-day stroke risk and a 22% 90-day stroke risk. In 2 days, yeah. So they've had a TIA. Somebody with a 6 or 7 has about an 8% risk of having a stroke within the next couple of days, and then a 22% risk within 90 days. 12, about 12. What's that? And that's about, it's about 8, just under 8, I think. Yeah, 4, sorry. But it's low, it's really low, 4. 4. So, but just keep in mind, right, the stroke risk within that 90-day window gets much higher with a higher ABCD2 score. In general, those patients will need to be admitted and they'll have to have their intervention worked up and treated during that hospitalization. So a lot of patients who come in, TIA, have a find their carotid occlusion, they get a carotid endarterectomy, a procedure within that hospitalization. Sorry. So the question was about like ABCD2 score based on where admission criteria. I would say in the old school days, a lot of the time, if there's no real significant deficits, a 4 to 5 would be like a stroke floor. And then with the plans to go to surgery, now it's really OBS or home pretty commonly with a follow-up plan within the next 30 days. It's a good question. Depending on the onset of symptoms, if there's really no infarct, you could call it falls, if there's really no infarct on imaging, it falls in the TIA category, definitively. You will hear people say, we were able to abort the stroke. The onset, based on the onset of symptoms, in general, most commonly, somebody will get their thrombolytic, have an onset. If they have really amazing treatment, you have immediate stroke recognition, you get to the hospital in 30 minutes, you get imaging immediately, you can have that door to needle time in 30 minutes, so your whole treatment is in an hour, which would be amazing. You can still have imaging show up. You can still have the stroke infarct show up on imaging. And even if it's small. So it could be called that. It technically falls in the TIA category if it didn't have an infarct on imaging. That's a good question. Yeah. So just pictures of the carotids. So in general, we have our, let me get back over my laser pointer. So when you're looking this way through, when you're looking at imagings that go this way through people, you have the vertebrals and then you have the internal carotids. The internal carotids are always kind of squiggly like this. And then our external carotids and our internal carotids. So ischemic stroke diagnostics, when we look at the important workup that happens when we're working up for ischemic stroke, and a lot of this is the same again between ischemic and hemorrhagic, but I'm just breaking it out this way. The rapid brain imaging, because that's how we're going to make our determination. We're going to talk about some of that. In EKG, because cardiac stuff and brain stuff go together all the time. So if somebody's having a cardiac event, it's very possible they're having a stroke. If they're having a stroke, it's very possible that they're having an MI. So we do need to do an EKG, troponins, that sort of stuff. And then priority labs, blood glucose, of course, because hypo and hyperglycemia are stroke mimics. We have to be able to know that. Serum electrolytes and renal function, especially if they're going to need to get dosed for contrast, just from that follow-up process. Coagulation studies, depending on, so there's a lot of things, and especially if your organization is moving from alteplase to tenecteplase, I would say that neurology, there's some neurologists who are like really aggressive, and then there's some who are really cautious, and they're allowed to be. So you will have some who will say, you know, their INR is 1.7, they took their DOACs, just their last dose was 2 days ago, they're a candidate. And then you'll have some who say we need to be outside of the 48-hour window, their INR needs to be 1.5 or less, things like that. So being able to make sure that, just understand that from that process. But overall, as nurses, we need to know their coagulation studies to be able to make sure they're safe to get that, what their INR is, their fibrinogen, and then if we know what their baseline is, if they bleed and we need to correct anything. And then CBC and cardiac markers of ischemia, of course. So imaging that we do, CT scan, computed tomography, a non-contrast head CT is good for that initial determination of what's going on with this patient. We know we have a neurologic event, we get a head CT, we're gonna make sure we're comparing for hypo or hyper densities. Hypo densities are dark areas, so that's a lot of the time like CSF, ischemia, things like that. Hyperdense areas are bright white, so that can be blood, tumors, calcifications, things like that. And we want to be able to make sure that in ischemic stroke treatment, there's no bleeding, there's no tumors. They're a good candidate for thrombolytic therapy. But hypodense areas, so we'll talk about some relative contraindications, but an acute stroke, ischemic or non-contrast head CTs, I apologize for being all over the place. Non-contrast head CTs have their limitations, right? So in that 24-hour window, an acute stroke is not going to show up on a non-contrast head CT. And so that is where its big limitation is at. This is historically, when I think back to when I started as an ICU nurse, I call the physician, I have this acute neurologic change. Okay, you always get an order for a non-contrast head CT. Let's just do a head CT. But that doesn't, it just shows a little bit of things. It doesn't actually show, you know, at that time when we didn't have code strokes, but, you know, you should have called one, because then you get the right imaging or comprehensive imaging to be able to make sure. And that's the important part about stroke imaging. So non-contrast head CT, right? We can see the ventricles where the CSF is. You can see areas of hyperdensity, if there is hyperdense areas or bleeding or things like that that show up on the CT scan. The other thing to know for the exam is the aspect score, the Alberta Stroke Program Early CT score. This is out of Alberta, Canada. It ranges from 0 to 10. It is a calculation that determines stroke size, severity, and time from infarct. It's focused only on the MCA territory. So parietal, little bit parietal, temporal lobes, MCA territory. A score of 0 is bad. It corresponds with diffuse ischemia throughout the MCA territory. So that's a more subacute or old stroke. It's not hyperacute. A score of 10 is assigned to a brain CT without early ischemic changes in the MCA territory. So 0 is bad, 10 is good. An aspect score of 10. That shows no ischemic changes. And right, if somebody has a subacute stroke, or they're outside of the window for that 3.5 to 4, maybe 6 hours, depending on your organization, outside of that window for tenecteplase or alteplase, and they have a score of 0, 1, or 2, they're not a candidate for thrombectomy or thrombolytic therapy because of the age of that stroke. If it's showing up on non-contrast head CT, it's not hyperacute. The CT angiogram provides a 3D rendering of the vessel anatomy. It helps identify vessel abnormalities, anomalies, occlusions, arteriovenous malformations, thrombosis, and also aneurysms. And then it can also give us a look at the collateral circulation. Considerations with CT angiogram is somebody's renal function, if they have an allergy to contrast dye, and sometimes a barrier can be being able to get IV access. So that can be a barrier to angiogram. These are the two different types of pictures that you get with angiogram. So you get that 3D vessel rendering that shows you what the vessels look like, and then the CT image, which will show where the dye is or is not. This person has a right ICA occlusion. You can see here on the left, nothing on the right. CT perfusion studies I'm personally obsessed with perfusion studies, MRI and CT perfusion. I just really find them fascinating. But a CT perfusion looks at that one moment in time for a patient. And so it assesses and evaluates perfusion to the tissue. It looks at the mean transit time of blood through the brain. It looks at cerebral blood flow. It looks at cerebral blood volume based on being able to get contrast dye. And so areas and it can help quantify the core infarct from the ischemic penumbra. So this is an example of the an image from a CT perfusion. It's the same slices of the brain on the right and on the left. And when you're looking at a CT scan, it's always your left is the patient's right and your right is the patient's left. That's always as you're looking at it. And so this is the same imaging, but you see the purple versus the green. The purple is the core infarct. That is the irreversibly damaged tissue. It has prolonged mean transit time. It has low cerebral blood flow. And then the green areas are the ischemic penumbra. And so it'll light up that way where you can see the volume difference then. If the areas light up or they line up and they're the same, then we don't have enough tissue that's salvageable for them to be a good candidate for IV thrombolysis. And then it can help quantify those areas. So in general, you'll see a lot of, if a neurologist uses CT perfusion, a mismatch volume generally over 40 is good. Under 40 is generally not enough salvageable brain tissue, commonly. A mismatch volume down on the bottom. So a mismatch volume over 40, commonly. Some neurologists are more aggressive and will do more with less, but on average, you'll hear that. So mismatch volume of 40 or more means there's a good amount of salvageable brain tissue. The purple is the tissue that's irreversibly damaged, the core infarct, and the green is the penumbra. I think MRI perfusion, rapid MRIs are going to be like our thing, but they give you the same kind of information. I'll show you some of that. They can compare, well, I'll talk about MRI in a second, but perfusion I like, but it's only this one shot in time. So we have had patients who've come through in a really good amount of time. The symptom recognition is fast. They get to the hospital in 15 minutes. Seattle is a lot of comprehensive centers. Their blood pressure is really good. So they have like a systolic blood pressure over 180 when they go into the CT scanner. And so they don't light up at all. Like but you know that really what's happening is that they're having good temporary perfusion on a really early stroke. And then also at the same time, if you have somebody who's like moving around a lot in the CT scanner, or they're like bearing down for 1 minute, the whole thing can light up purple and green. And so there's a lot of cases people will point to, they'll be like, this is not that useful. But the perfusion imaging itself, making the determination between where's the core infarct and what tissue is at risk, I think is going to be the gold standard. I think it's going to be with MRI, and I'll show you why. With MRI, a lot of the research shows the ability to compare DWI sequencing versus FLAIR sequencing. So DWI is diffuse weighted imaging, and FLAIR is fluid, attenuated, inverse, something or others. Doesn't really matter. But what you're comparing is the way that diffuse weighted imaging lines up with a magnet. The water molecules get pulled in a very specific way. And so the area that is immediately ischemic or damaged, there will be restricted diffusion of water molecules on those imaging. FLAIR looks at the development of cerebral edema, cytotoxic edema. And so the development of cytotoxic edema takes about 6 hours. So if this area is present on DWI, but it is not present on FLAIR, that's a hyperacute stroke under 6 hours of age. And the closer that those sizes get to match, they can age that stroke down to like 30 minutes. So if it's 3.5, 4 hours. So the use of MRI has allowed a lot of organizations to extend their window of symptom onset to 6 hours, because we've actually realized that the MRI is better at quantifying it than people are reliable in reporting their symptom onset. Oh. I would say the opposite. I would say a lot of organizations have protocols where, so like, I think Texas, there's a bunch of hospitals in Texas and stuff that maybe you guys work at them, but they just use MRI for everything because they can get all the information that they need. And then we use CT perfusion pretty broadly. And we have some physicians who really like the MRI and the rapid MRI, but we, like, our organization has adopted it. Previously, I was at one that had a determination if it was, we could use either based on the stroke onset and the patient condition. So every place is just a little bit different. The important piece is looking at, we have 2 ways now of getting perfusion imaging. Yeah, the rapid MRIs for stroke, you get 2 sequences. They take about 10 minutes, which is about the same as a CT scan. And so if you do have a 2 MRIs and you have the ability to have a dedicated one to rapidly get people through, that you're not going to be like, you have 1 MRI and you have somebody getting a spine MRI, for like surgery workup, and they're in there for an hour and a half, that you can flip over pretty fast. The rapid MRI process and getting those 2 sequences, about 10 minutes. For the brain. So it actually works pretty well. But yeah, everybody uses them differently. There's no like right, wrong, but I like to just nurses to be able to be aware of how we use perfusion imaging and the 2 possibilities that exist for perfusion. So CT perfusion or MRI. And then a lot of organizations use MRI to determine, follow-up after 24 hours to be able to quantify permanent infarct or not, in the presence of an area of infarct or not as well. Yeah. So the question was, if we couldn't use a CT angiogram, would we do an MRI? Yes. The only barrier really to MRI, especially emergently, is if they have a pacemaker, is being, that's pretty standard barrier. But if you can't get IV access, then you can use an MRI, which is pretty helpful. A lot of patients with complicated vasculature, we all know, right? Hard to get IVs on. So this is an example MRI, the different sequencing. So between the presence of flare and diffusion, so DWI, this is an ADC image, but you can see this here correlates with this here, right? So this is, when they line up, we know that we have the area of restricted diffusion of water molecules and the development of cerebral edema or cytotoxic edema. And that shows us that that is the area of infarct. If it's present on DWI, but it's not present on FLAIR, that's a hyperacute stroke. And so that's somebody who would be a good candidate. They have not started developing cerebral edema yet. And so that means it's a really new infarct. It's pretty amazing. I think this is going to become a pretty big standard nationally. I think it's going to help us individualize patient care a little bit too. All right, so interventions for ischemic stroke. IV thrombolytic therapy. Outcomes are best administered as close to the stroke onset as possible. Again, keep in mind the goal door to needle times less than 60 minutes from hospital arrival. That's in your book and get with the guidelines. Every organization may have different guideline goals, where ours are to be less than 40 minutes, but for this test, it's less than 60. In general, the window for IV thrombolytic therapy is 3 to 4.5 hours, as close to minute zero as possible from last known well. While many organizations have switched to tenecteplase, you're still going to be tested on this on alteplase. Alteplase is the FDA approved, the only one that's FDA approved for thrombolytic therapy for ischemic stroke. Tenecteplase is not, but of course there's a lot of literature and research on it, and many organizations have switched. So alteplase administration dosing is weight-based. You need an actual weight, not a stated weight. We go through, I was just saying in my system, we have one small standalone emergency room that has one scale that can get a weight. And so we need to do better because that place gives the system wants it to be an urgent care, but it actually gives the most tenecteplase in our system. And so we have to estimate too much or move patients around too much. And so, but that's an important thing. The actual weight, not the stated weight. And the dosing for alteplase is 0.9 milligrams per kilogram of an IV infusion to a maximum of 90 milligrams. If the patient weighs 100 kilograms, they get 90 milligrams. If they weigh 120 kilograms, they get 90 milligrams. So no more than that. With dosing of alteplase, maybe some of you still give alteplase. I've done both. It's 10% of the dose in the first minute with the remainder over 1 hour. And then it has to be followed by a normal saline flush to get all of the alteplase out of the line. So with IV thrombolytic therapy, we want to be able to make sure that they have patent IVs and then assess for contraindications. So absolute versus relative contraindications. And this is going to be a consideration, again, in reality, in the real world. It's really, some of us are going to work with neurologists who are really aggressive and some who are very cautious. And so recent surgery within 14 days is relative. If we know they have a drain and we know they might bleed, but we can deal with it, let's do this. Active bleeding and active GI bleed, if they're admitted with GI bleed and have a stroke, they're probably not going to be a candidate for IV thrombolytics. Stroke or head trauma within 3 months, that's an absolute contraindication. If there's an area or head trauma within 3 months, that is going to bleed. So recent stroke, recent ischemic stroke, recent traumatic brain injury, that area will just have a hemorrhagic conversion completely. Current oral anticoagulant use or heparin within 48 hours. Like I said, some physicians will give IV thrombolytics if they've had a DOAC over, like they missed one day, because with DOACs especially, you have to take them every day and you have to take them at the same time. You can develop clots if you miss a day or two. And so the stroke risk, you don't even have to go a week, really. And so some of them will say, we know it's been at least 24 hours since they've at least had a dose, and they're having an acute stroke, we'll give them, and some will wait even a couple more days. NIHSS greater than 25 or CT demonstrating greater than 1/3 of the hemisphere is infarcted. That's a pretty severe stroke and generally a contraindication because it'll bleed. And then blood pressure greater than 185 over 110. So our goal for administration of IV thrombolysis is less than 185 over 110. And then we have to get it down to less than 180 over 105. So be able to make sure that we give the dose, the full dose over 1 hour, the 0.9 milligrams per kilogram. 10% in the first minute, and then the rest. Administer through a dedicated line. Be sure that patient gets all the dose in the line. And that's why we use the normal saline infusion. And then the actual, using an actual patient weight, not an estimated weight. And then in general, again, gross assumption, because not everybody does it this way, but intensive care level assessment post IV thrombolysis. Some organizations, just from a practicality standpoint, have gone to low intensity versus high intensity. If their stroke score is low and they don't have any blood pressure issues, they can be out of the ICU in 10 hours. Some organizations are still at 24 hours. Some organizations don't admit to the ICU at all post, they just have frequent assessments on IMC or tele. Very different. In general, though, the gross assumption is that you go to the ICU for the first 24 hours after IV thrombolysis. And then good consideration or an example of vital sign expectation and monitoring post-IV thrombolysis is Q 15 minutes for the first 2 hours, Q 30 after that for 6 hours, and then Q 1 hour for the remainder of the 24 hours. You're most likely to bleed and have a hemorrhagic conversion that first 6 hours. And then once we have to have the blood pressure less than 185 over 110 to give the alteplase, then we need to get it down to less than 180 over 105 for the 24 hours afterwards. And then lots of education about the meds, the side effects, right? And then keeping in mind that people who are experiencing acute stroke are not great learners. That's just their brain is going through something right now and they'll get back to you, but not just right now, right? They're not great learners and we have to remember that. So lots and lots of education and engagement with the family. So we look for risks based on the IV thrombolysis. Symptomatic ICH occurs about 6% of tenecteplase and alteplase cases. Technically, they're very similar meds. But that hemorrhagic conversion risk is about 6%. You will see with the development of a hemorrhagic conversion, deterioration or a change in the neuroexam, and that's part of the monitoring. You see an increase in that NIHSS score that it could possibly be, or they've had right-sided deficits and now their left arm is weak. All of that can be related to possible hemorrhagic conversion. Bleeding anywhere in their body, very possible. So minimizing invasive procedures, preventing injuries, maintaining safety. I would say that some places still require bed rest for 24 hours. Some places are mobilization or activity only when supervised. I would say bed rest for 24 hours kind of going out, which is good, going away, but really focused on safety and minimizing the risk of injury and harm in that first 24-hour window. And then angioedema is an emergency and occurs about 1% of the population who receive IV thrombolysis in that tissue plasminogen activator group. People who are on ACE inhibitors are higher likelihood of having that angioedema experience. But it is an allergic reaction, it is an emergency, and if somebody has that reaction, they would not ever be able to be a candidate for alteplase or tenecteplase again. When we look at hemorrhagic transformation treatment, our standard reversal is the administration of cryoprecipitate. It contains clotting factors for fibrinogen, factor 8, von Willebrand factor, factor 13, and fibronectin. It's stored frozen and must be transfused within 6 hours of thawing. It's indicated for acute bleeding or with significant hypofibrinogemia. I can never say that. Put it in here. Should just write low fibrinogen. And then usually transfused in pools of 10. Hypofibrinogenemia. There we go. Got it a second time. Questions? Yeah, dosing for tenecteplase, we'll talk about it, but it is 0.25 milligrams per kilogram for the stroke dose. It's been researched at all levels, but what was kind of determined in the research is like 0.25 and 0.4. 0.25 was the safest. But 0.25 milligrams per kilogram for tenecteplase. Oh, interesting. Yeah, question was, do I know anything about administering Connect to Place IO? I don't. I know there's some research, but I haven't seen anything definitive. Currently, all of the guidelines still say to administer via IV. Pregnancy and IV thrombolytics. I've heard most organizations and in the literature, everybody's still sticking with Alteplase from a predictability standpoint. It's the tough part too with pregnancy. We know the risks are here. We know even though it's more complicated, tenecteplase is probably fine and probably the same safety and efficacy. I think nobody's going to do a study on it. So I think but for right now, as I know, most places are sticking with Alteplase with pregnancy. The placenta, the tenecteplase doesn't, right. Yeah, that's as I know it, and that's mostly why people understand its safety to be that Alteplase doesn't cross a placenta. And so the fetus isn't at risk for bleeding in that same way. Yeah. And that's the assumption with the tenecteplase as well. I just don't know that anybody's willing to make a jump yet. And peds, most places are sticking with Alteplase for peds still with dosing, but I'm sure somebody will make a jump to tenecteplase. I don't think so. Tenecteplase. I don't think so. I think it's still going to be a little ways out with FDA approval. Yeah, they don't.